Hello and welcome to this short webinar. So today's webinar is going to be on transfusion-associated circulatory overload. So the webinar will involve a 40 to 45 minute presentation, which will be followed by a Q&A session and then a feedback poll at the end. So just a couple of housekeeping notes before we start. So please keep your microphones muted for the duration of the webinar. There'll be no chat facility during this webinar, so if you've got any questions, just pop them in the Q&A box and we'll aim to answer these during the session. So I'll just introduce you to today's speakers. So we've got Dr. Sharon Gray, a haematology consultant, clinical scientist at Blackpool Teaching Hospital, NHSFT. We've got Dr. Helen New, consultant in Pediatric Transfusion Medicine, NHSBT. We've got Dr. Tom Latham, consultant haematologist, NHSBT and University Hospitals, Bristol NHS Foundation Trust. We've got Dr. Andrew Bentley, consultant in respiratory medicine at Manchester University NHS Foundation Trust, clinical lead of the Northwest Ventilation Unit and honorary professor at University of Manchester. We've got Dr. Paneet Malhotra, consultant in respiratory medicine at St Helens and Knowlesy Teaching Hospital NHS Trust. We've got Dr. Shruti Narayan, the SHOT Medical Director and Consultant Donor in Medicine at NHSBT. So we've got the webinar discussions, which will also be moderated by the SHOT team members. We've got myself, Jess Ryan, Incident Specialist, we've got Emma Milsner, the SHOT Haemovigilance and Patient Blood Management Specialist, we've got Cy Carter Graham, Clinical Incident Specialist, and Nikki Swarbrick, the Laboratory Incident Specialist. Okay, over to you, Sharon.
Thank you very much, and a massive thank you to everybody for joining us today. So this is the outline of the webinar for today. We're going to look at some definitions for the pulmonary complications of transfusion. There'll be some clinical vignettes and learning from short reports, and also at the end there'll be a panel discussion for our Q&A that we've just heard about. Okay, so the pulmonary complications of transfusion, there are three that we currently recognise in haemovigilance, and they are TRALI, TACO and TAD. And you'll see that these circles overlap one another because they have quite a complicated relationship to one another, and I hope that will come out in the presentation as we go through. And this really puts me in mind of the three-headed goddess Hecate, and she has been described as intrinsically ambivalent and polymorphous. She straddles the conventional boundaries and eludes definition, and this very much reminds me of the pulmonary complications because they can coexist. They may well represent a spectrum. They're certainly very difficult to differentiate, and all are very much limited by incomplete data. This is some headline data from the 2020 SHOT report, which was the last reporting year. There were 188 pulmonary reports received, of which unfortunately there were 23 deaths and 33 cases of major morbidity. In most years, there are usually slightly more females than males affected, and this age demographic data here reminds us that this is not just a condition of adults. We also see this in paediatrics and neonates too. Looking at the graph at the top there, reports by year, you can see that in 2017, the number of reports really took off, and I think this was probably related to the 2017 National Comparative Audit of TACO, and I think that did quite a lot to raise awareness of TACO amongst those of us who do haemovigilance reporting. The other thing to note there is that you'll see that the TAD cases have been somewhat up and down over the years, and I think that probably is reflective of the changes in the definitions for the pulmonary complications of transfusion. Usually involves red cells, of course that's the most components that we transfuse, but it also affected our platelets and plasma, and also multiple components in patients that have major hemorrhage. So the data that we can see here is the mortality data between 2016 and 2020. The different colours on the chart that you see there, it relates to the imputability. So whether or not the death was definitely caused by the transfusion, probably or possibly. But I think that the important message here is that 1/3 of TACO deaths reported in that period were deemed to be preventable. And we all have a responsibility to do what we can in our haemovigilance systems and in our hospital systems to make sure that transfusion is as safe as possible. So defining TACO, this has been quite difficult over the years, I think, but I can give you an update. This is the definition that we use for SHOT at the moment, and indeed is used internationally in many haemovigilance organisations. So TACO is defined as acute or worsening respiratory compromise and/or acute or worsening pulmonary edema during or up to 12 hours of transfusion, with additional features including cardiovascular system changes not explained by the patient's underlying medical condition, and that can be quite complicated, but also evidence of fluid overload and a relevant biomarker. And that biomarker is BNP, and I'll be talking a little bit more about that later on. There is also a little caveat there that says that SHOT accepts cases up to 24 hours. So that may be a little bit different on an international level by comparison. And I think in the last reporting year, we accepted 8 cases between 12 and 24 hours. So in 2019, this paper was published, and it is the revised international surveillance case definition for TACO, and it's a classification agreement validation study. And really the objective of this work was standardization to produce an internationally consistent surveillance and reporting criteria. And what we've noticed in accordance with the 2011 ISBT definition is that a lot of cases were highly likely or probable cases, but they didn't actually meet the definition. So it kind of raised some interest and we were thinking, well, maybe we need to do something about that. Maybe we need to change the case definition. And so there was a very extensive iterative validation process between 2017 and 2018. And to put all of that work into a very small nutshell for you, the final adopted version shows 76% positive agreement and 37% negative agreement on cases that were assessed by people who do haemovigilance assessments. And just by comparison, that rate was about 50% on the 2011 ISBT definition. So this was quite a substantial improvement. But what we know is that it's not effective in distinguishing between the pulmonary complication categories, and it was never intended to solve that particular problem. So these are the criteria, and it requires a patient to have these categories fulfilled within 12 hours of transfusion, and like I said, SHOT accepts cases up to 24 hours. So there should be at least 3 or more criteria scoring positively on these criteria. So A and or B, so there should be respiratory compromise and or pulmonary edema present. And the additional criteria are cardiovascular system changes that are not explained by the patient's underlying condition. There should be evidence of fluid overload, whether that's a positive fluid balance or clinical improvement following diuresis. And a supportive biomarker. So in essence, that is BNP, and I'll talk about that later on. So there should be at least 3 present, A and or B, plus additional criteria. So the pathophysiology of TACO is complicated and a subject of much research, and I think this diagram by Bosboom and colleagues is quite helpful to illustrate that. So if we start in the top left-hand corner, this is the current TACO hypothesis, the traditional model, if you like. And so what this says is that increased hydrostatic pressure within the capillary forces fluids through the endothelial barrier, and that enters the alveolus and fills it up basically with fluid, and that causes pulmonary edema. So this is due to increased interstitial pressure and fluid moving from the capillary into the alveolus, causing pulmonary edema. There are 3 other alternative mechanisms that have been proposed, and if we go down to the bottom left-hand corner there is also a trolley-like response that has been proposed that involves activated neutrophils and macrophages. So what happens here is that the endothelial barrier of the capillary is disrupted. There is also disruption of the epithelial barrier in the alveolus, and transudate and exudate will pass across that interstitium and move into the alveolus, again filling it up and causing pulmonary edema. Then if we move to the bottom right-hand corner there, this is more of a mechanical destruction kind of model. And this is caused by pressure-induced permeability, or what we might call barotrauma. It disrupts the glycocalyx, and again, transudate and exudate crosses the interstitium and fills up that alveolus with fluid through that disrupted epithelial barrier. And then the final proposal for what might cause this type of response are storage lesions, and sometimes these are known as biological response modifiers. And they are microparticles that are present in the blood. They're less than 1 micron in size, and they might be produced by activated cells or by apoptosis. And again, these cause vasoconstriction. It squeezes fluid out of the capillary across that disrupted epithelial barrier and fills up the alveolus, causing pulmonary edema. So there are a number of different proposed mechanisms that could cause TACO and pulmonary edema in these patients. So clinical features of TACO and challenges of differentiating the pulmonary complications of transfusion. This is very challenging. So if we move to the next slide, how do we distinguish TACO and TRALI, and what is the driver of lung edema? Well, it's not so straightforward as we've probably gathered from the previous slide. There may be an inflammatory component that's caused by increased capillary permeability as a TRALI ARDS type of response, requiring a two-hit theory, perhaps something that is present in the patient and something that is related to the transfusion, for example. It may be related to a hydrostatic issue where there's increased capillary hydrostatic pressure, such as in heart failure, TACO, and it's often not proportionate to the volume transfused. So this may not be a simple plumbing problem of too much volume in that overwhelms the circulatory capacity of the patient. Something else more subtle may be happening, and indeed these things may not be mutually exclusive. And we do chest x-rays in our patients who have respiratory complications of transfusion, and that's not always going to solve our problem of how we're going to differentiate between TACO and TRALI, because both of these situations cause pulmonary edema. I think that there are a number of radiological features, and I'm not going to list them all here, that probably would favour TACO, and I'm not a radiologist, so I'm not going to go into the detail of this, but would perhaps help favour TACO over TRALI. But these features are not TACO specific, and so we can't delineate between them, and we're not going to know from a chest x-ray, in other words, whether or not we're looking at a case of TACO or TRALI. So those patients that have circulatory overload have left atrial hypertension, LAH. And demonstrating this is not without its challenges, and it's not helped by incomplete and unavailable data. And when we looked back in the 2018 short report, it was noted that 9.1% of patients had had an echo, and only 2.7% of patients had had a BNP level done. Now, to be fair, it might not be required to clinically manage that patient, so we shouldn't perhaps be surprised by that. And we're not saying that you should do this specifically to help with haemovigilance categorization. But we do know that BNP is a surrogate for left atrial hypertension, but it does have its limitations, and there is a systematic review there if you wanted to look at that in more detail. But we know that a normal BNP really excludes TACO, so it's got a good negative predictive value. And there are papers providing us with evidence to show that a 1.5 times increase supports a diagnosis of TACO. And often it's raised pre-transfusion as well, because these patients often have underlying heart failure. Well, the problem is that it's unreliable in critically ill patients, and BNP is a renally cleared molecule. So patients who have renal failure will have higher levels compared to those that don't, and that might muddy the water somewhat if we're trying to use it to support evidence for LAH. And indeed, other biomarkers require further investigation. That is a subject of ongoing research. So about the time we were looking at the new surveillance definition for TACO, there was also work going on for a consensus redefinition for TRALI as well, and this was work undertaken by Vlaar and colleagues, and it was published also in 2019. And what they said was, for a definition of TRALI, there should be acute onset hypoxemia and pulmonary edema within 6 hours of transfusion. And they differentiated between type 1 and type 2 TRALI, where type 1 TRALI, there are no risk factors for acute respiratory distress syndrome or ARDS, and that might be sepsis or major hemorrhage, to name a few. There are others, of course, as well. And importantly, there is no evidence of left atrial hypertension, so we're not looking at the overloaded patient that probably has TACO. Or the type 2 TRALI, where the patient does have risk factors already present for ARDS, but they were pre-existing and they were stable. And again, no evidence of LAH. And those patients that were categorised as having ARDS, in effect, they were deteriorating over the last 12 hours. So this doesn't favour TRALI because they were already deteriorating. So it's probably ARDS for a non-transfusion underlying reason. The consensus definition also recognises TACO and TRALI and also acknowledges that they may coexist. It recognised TACO, where LAH must be present in order to categorise a case as TACO, and anything that didn't fall into any of the above categories and was in temporal association with transfusion, so the timing was right for it, in other words, was categorised as TAD, so transfusion associated dyspnea. And there are other challenges too. So comorbidities and concurrent diagnosis complicate the evaluation and may contribute to the reaction as well. So that can be quite a complicated thing to untangle when we're trying to categorise the pulmonary complications. We also know very well that fluid balance is not well recorded, so we can't always rely on it. But we also know that positive fluid balance is a risk factor for both TACO and TRALI. Also, response to diuretics is not well recorded, and especially the volume of diuresis, and that might be impaired by renal failure as well. Unanticipated changes in cardiovascular status can occur in both TRALI and TACO as well, so that is also not necessarily helpful, although hypotension is more common in TRALI. We also know that fever can be associated with both TACO and TRALI, and we analysed this in the 2017 SHOT report, and it was also studied by Palmer and colleagues in 2016. So that really supports an inflammatory component to TACO as well as TRALI. Now, blood transfusion may not be the only cause of circulatory overload. Certainly iatrogenic fluids are important, and the patient's underlying comorbidities as well. So what I mean by that is that it affects imputability. So if a patient has a 2-unit transfusion, but they're 7 litres positive before the transfusion, I can't blame the blood for the TACO in full. So what that does, it reduces the level of imputability, and imputability levels go between 0 and 3. Also, comorbidities that might have related to the patient being overloaded as well, such as heart failure. So the patient may have already had overload because of heart failure or renal impairment. So again, this affects the imputability level, but doesn't mean to say that it's not TACO. Okay. So looking at TAD now, transfusion-associated dyspnea, this happens within 24 hours of transfusion, and it is not categorised as TRALI, TACO, or allergic reaction, or something that's to do with the patient's underlying condition. And in 2020, there were 37 cases involving 4 deaths and 4 cases of major morbidity. Every year, the pulmonary working expert group, of which I'm part of, look at all of these cases, and we try to classify them. And this is a summary from the 2020 report. So of those 39 cases, 35 were categorised as TAD, 2 did meet the definition for type 2 TRALI that we've just looked at, and 2 were withdrawn for other reasons. Now, the ones that were categorised as TAD, we call them either TAD-C or TAD-IC. TAD-C being where it meets the criteria for TAD, and we have all of the data that we would wish to have in order to make a proper categorisation. TAD-IC is where we don't have the full data to do a categorisation within the pulmonary complications of transfusion. So some of this is to do with lack of available data, and that's always going to happen. But the important thing for this is that TAD, it's an important repository for building a case series, because we can look back on it in the future when more research has been done and we can reanalyse these cases. Okay, so mitigating the risk of TACO. The use of the checklist or risk is a risk assessment, but I think in common parlance we started calling it a checklist, but in effect it's a risk assessment. First introduced as a recommendation in the 2015 short report, and it was based on thematic analysis of risks and comorbidities of the things that we know are risks for TACO, such as heart failure, renal impairment, etc. And these cases were audited against this checklist in the 2016 report, and it was found that about 80% of cases showed at least one positive feature on the checklist. So that doesn't imply prevention, but validated the sensitivity of the checklist for identifying those patients at risk of TACO. So this is the risk assessment or checklist, and this was the recommendation too that we see here. A formal pre-transfusion risk assessment for transfusion circulatory overload should be undertaken wherever possible. And what this tries to do is ask the assessor to think heart, lungs and fluid. So does the patient have any risk associated with the heart, such as pre-existing cardiac dysfunction? Are they on a regular diuretic? Do they have severe anemia, which we think is an independent risk factor for TACO? Is the patient known to have pulmonary edema, or might they have pulmonary edema? Have they got a positive fluid balance? Are they receiving fluids? Is there any peripheral edema, low albumin? Do they have significant renal impairment? And if the answer is yes to any of those, the risk assessment is asking, does this patient need a transfusion? Because of course, the safest thing to do is nothing. The safest transfusion is the one that doesn't happen, of course. So do we really need to transfuse a patient who appears to be at risk? Can we safely defer it, investigate it, or treat it? And with the best will in the world, sometimes we do need to continue with transfusion in the patient's best interest. So we need to think about mitigation. So those might be body weight dosing of red cells. So only giving a volume of red cells to meet the patient's hemoglobin target. Single unit and review, measuring the fluid balance, using a prophylactic diuretic if it's not contraindicated in that patient, monitoring the patient more closely, including their oxygen saturation. So there was a recommendation for using weight-adjusted red cell dosing in the last few reports for SHOT, and really the learning point from this was excessive volume of red cell transfusion to meet the hemoglobin target remains a significant factor in cases of TACO in non-bleeding patients, and that's why that recommendation was made. There is a recommended resource down there for the red cell dosage calculator, which I was involved in, that may be of interest to you. So use of the TACO checklist. Well, this was slightly underwhelming, unfortunately, but let me share that data with you. We found that it was performed in about 27% of cases, and of those cases where it was performed, in 70 cases, a mitigating action was identified as being required. But in only 50% of those cases were all of the actions performed as intended. And of those cases where the risk assessment was performed but a mitigating action was not identified as being required, of which there were 30%, when you go back and actually look at the detail of those cases, actually 3/4 of them had at least one risk for TACO. So it's not being used particularly well in terms of how often it's being used, and also it doesn't appear to be being used in the right way at the moment. So let's just remind ourselves of some headlines from the National Comparative Audit of TACO in 2017. So just quickly, what we knew all along was insufficient recognition of patients at risk of TACO, that it's underdiagnosed. We always knew that, I think. It's that it's undertreated, that it's underreported. We always knew that. Lack of monitoring of the patient, and lack of mitigations put in place for that patient, whether that is a prophylactic diuretic or the use of a fluid balance chart. So this really asks the question, is it now time to re-audit? Okay. So I'm just going to quickly go through some illustrative cases for adults, and this was I will call this a textbook case, but perhaps not all cases are a textbook. They're all complicated to some extent, but this was a case of the checklist being omitted in a patient, resulting in overtransfusion, and where a structured investigation was not performed. So in this patient, he was in his 70s, weighing 64 kilos. severe iron deficiency anemia, hemoglobin 47, pre-transfusion CT scan showed pulmonary fibrosis and a small pleural effusion. He had severe heart failure, renal impairment, peripheral edema, and was on a regular diuretic. He had a lot of risk factors for TACO, in other words. He was given 2 units. A TACO risk assessment was not performed, no fluid balance chart. His post-transfusion hemoglobin was 65. He was then, for some reason, given a 3rd unit of red cells. There were no signs of active bleeding. He became wheezy, hypertensive, tachycardic, pyrexial, and had rigors. SATs down to 75%, and he had peripheral pitting edema. Post-transfusion chest x-ray showed some consolidation, but also some new bilateral infiltrates that were consistent with pulmonary edema. He was treated with oxygen by CPAP, given a diuretic plus other things, and he was transferred to HDU and thankfully later recovered. The local procedural review identified a single unit in review and not transfusing blood for iron deficiency as the corrective actions. So if we just look at that in a little bit more detail on the next slide, what was evident was that this patient had multiple risks for TACO. The assessment checklist was not performed, but would have identified all of those problems that that patient had. And there were no reported mitigation actions taken. Single unit and review, IV and IV iron would have been appropriate for that patient. 3 units is excessive in a small patient with no active bleeding. And TACO was almost inevitable in this scenario. So the TACO structured investigation tool would have highlighted the medical management and single unit, which the local review identified. But in addition to that, it would have identified weight-adjusted red cell dosing, the use of a fluid balance chart, more frequent measurements of oxygen saturation, a prophylactic diuretic in addition to his regular medication if that had not been contraindicated for that patient. Okay, so this was a more difficult case to categorise. Female in her 80s, given 2 units of blood for iron deficiency anemia, pre-transfusion renal impairment and peripheral edema. So there's some suggestion that this patient may have overload to begin with. A TACO checklist was not performed, and a diuretic that was intended to be given was not given. And during transfusion, this patient had an increased respiratory rate, hypertension and tachycardia, which was complicated by a history of atrial fibrillation, but actually only 2 TACO criteria were met by the criteria that we looked at earlier on. So the respiratory symptoms and probably the cardiovascular changes as well. But in other words, it didn't meet those 3 things that we should. So there's no fluid balance, no chest x-ray, not treated with a diuretic, BNP wasn't tested, but the patient did recover. Likely TACO given the background, but insufficient criteria, and therefore it was categorised as TAD-IC. Okay, next slide, please. Okay, so I'm now going to hand over to Dr. Helen Yu to take us through the paediatric illustrative cases. Thank you, Helen.
Thank you, Sharon. So I'm just going to give you a little flavour of some of the paediatric cases that have come up to SHOT, which are all reported as well in the main TACO chapter. Overall, over the last 10 years, this slide shows the relative percentage of paediatric TACO cases compared to adult TACO cases. The paediatrics are in blue and the adults are in orange. And overall, the paediatric TACO cases are 2.2% of paediatric SHOT reports, whereas for adults it's a higher percentage at 6.1%. But this could be because we have relatively higher proportions of some of the particular errors in paediatrics. For the last 10 years, there's been a total of 29 paediatric TACO cases, so the numbers are small and they fluctuate, but we have got a number that we can sort of draw conclusions from, and that includes 9 in neonates. Overall, the paediatric TACO cases are 2.9% of overall SHOT TACO cases. So the first illustrative case I have is of excessive transfusion rate, and this is a good example of one of the errors that we see reported relatively frequently to SHOT, where a child was transfused with a high volume either due to prescription, administration or pump errors. And in this case, a 15-day neonate on the pediatric intensive care unit was transfused with 53 mils of red cells over 15 minutes rather than the 4 hours that it had been prescribed for due to incorrect setting of the infusion pump. And the baby required furosemide for mild circulatory overload. That's a classic type of pediatric shot type reports which can lead to TACO. The next case is where there was an excessive volume and rate prescribed. A 1-year-old child became hypoxic following a stem cell transplant with evidence of pulmonary edema on a chest x-ray during the first 2 hours following transfusion of 1 unit. It was described as platelets over 1 hour and 156 mils of blood over 2 to 3 hours. So if you, for a year-old child who might have been around 10 kilos, this would be approximately 20 mils per kilo of platelets over that first hour. So that is actually within pediatric guidelines for volume, which I'll come on to in a moment. But it was 15.6 mils per kilo of red cells over 2 to 3 hours. So that was what we would say the high volume and rate, because the top-up transfusion for a child is usually approximately 8 mils per kilo, given at 5 mils per kilo per hour. So this was a high rate and volume. So it's really important for pediatrics that we say that all transfusions should be weight-based in mils, and it's very important that those prescribing for children should be properly trained. And it's also important to note that actually for children and neonates, they generally receive larger transfusion volumes per kilo than adults for red cell top-ups and platelets. Really, it's a way of minimizing donor exposure. But at the same time, and this is not actually evidence-based, it's just historical practice, and it's particularly the case for neonates. So I think that is something we should be considering in the future, really, when thinking about TACO for this group. Another situation where we've seen TACO reported in pediatrics is for complex procedures where fluid balance can be an issue if they're not monitored properly. And a classic one of those in pediatrics is neonatal exchange transfusions. These need meticulous monitoring, including fluid balance and hemoglobin levels. And in this particular case here, a preterm infant actually died due to TACO. They required a double volume exchange transfusion for high bilirubin at birth, but deteriorated markedly an hour after the procedure commenced. And it was noted that nearly 3 times the required volume had been administered than had been removed. And this was due to 3 syringes of blood being accidentally run concurrently. And this illustrates the issues that can occur when one's dealing with such complex procedures. The baby became very unwell, had an intracranial hemorrhage. And although this particular neonatal unit performed 5 to 10 procedures per year, that's more than many neonatal units would perform. This is sufficiently infrequent that many nurses and junior doctors will have had limited experience. Finally, pediatric TACO can still occur with small volume transfusions, illustrating that some of the patients are very vulnerable, and along with the messages that Sharon's been giving, it's very, very important to think about the underlying condition of the child. And this is a case where an 18-year-old preterm neonate with intrauterine growth retardation who'd been born severely anemic with a hemoglobin of 63 grams per litre was given a top-up transfusion of a standard volume, but developed respiratory distress subsequently, and was diagnosed with possible TACO despite that. So there are particular challenges and unanswered questions in paediatrics. Certainly there are complex patients in many cases, and the symptoms of the underlying disorder may be difficult to distinguish from TACO. There may be underreporting. As I say, we see a different proportion of paediatric versus adult cases, although without good denominator data, we can't be sure whether this is simply due to a relatively higher proportion of errors that are reported. And for neonates in particular, TACO and other pulmonary complications may be under-recognised, and I think it would definitely be helpful to have more neonatal-specific TACO definitions to be sure that we're not missing neonatal TACO through using standard definitions, but that clearly requires a lot of work and research in order to define these properly. For children, the adult checklist, which has been developed by Sharon and colleagues, provides very helpful pragmatic guidance, I would say, in the same way for pediatrics, or in terms of the principles, although, for example, the specific cardiac diagnoses leading to the vulnerabilities are different. For neonates, again, the same broad risks are there, but again, there are particular neonatal specific vulnerabilities. So this is something that can be developed for the future, although I think using the same principles applies for pediatrics as for adults. And for pediatrics, as I've already tried to stress, I think it's training and education around correct prescribing and administration is fundamental, and that's in many ways the most important message, I think, for TACO prevention for neonates and children. So I'll hand back now to Sharon for the rest of the TACO talk.
Thank you, Helen. So I just wanted to mention something about structured review of TACO cases. We go to the next slide, please. There was been a recommendation in the last couple of reports about doing a structured incident review for every case of TACO, because of course this is not just about the case that you are investigating. This is about having safe systems and practices for all of the patients in the future. So I'm not going to go into the fine detail of this, but you can find this resource on the SHOT website. There is a link to it there. The next slide, please. We're left with a number of unanswered questions, and similarly to what Helen's gone through with the neonatal and paediatric ones, and I think these are probably the top questions. Vigilance reporting implications relating to the TRALI new definition for the that was published in 2019. This is not validated at the moment for haemovigilance, and so we are in discussion about how we might tackle that at the moment. We don't know the effectiveness of risk controls that we can currently take, like the use of diuretics and the TACO checklist, for example. We don't know whether there's any long-term sequelae for patients who have had long-term, who have had pulmonary complications in the long term. More work needs to be done on biomarkers. So we know something about BNP, but there will be others, I'm sure, in the future. We need to understand more about the pathophysiology of pulmonary complications. I think things are emerging, but I think we're right at the beginning of that work, really. And also the big question about the use of prophylactic diuretics. There has been a Cochrane review that didn't find one way or another about whether or not we should be using prophylactic diuretics to avoid transfusion-related morbidities. Next slide, please. So I think we'll be going around this Mobius strip for quite some time, hopefully refining what we know and what we do. But the key message from SHOT is that patients who develop respiratory distress during or up to 24 hours following a transfusion, where you suspect the transfusion to be the case, please do report that to SHOT, because don't get too hung up about what category it goes in. We can discuss that within SHOT. So the important thing is that they are recognised and reported. Okay, and I just wanted to point out some recommended resources there. So you can find more information about the weight-adjusted red cell dosing there, and the investigation and preventive action guidance tool that I just went through on the previous couple of slides. The TACO checklist can also be found on the SHOT website, and there is also an algorithm, that SHOT Byte number 11, which is an algorithm that helps differentiate between the different pulmonary complications. Okay, and if we go to the next slide, there's also recently developed a video about TACO, which has had lots of great feedback, so please watch that on YouTube if you have time. I think it's about 8 minutes long. There's also the SHOT app and another number of other resources that you can find on the SHOT website as well. I'll hand over to Shruti. Thank you.
Thanks very much, Sharon. It is actually just to remind people that now we have an annual symposium. This time we are celebrating the Short Silver Jubilee. It's a special year, and we are organizing this jointly with International Hemovigilance Network. The theme of this conference would be Hemovigilance Past, Present, and Future. The dates are 6th to 8th of July, 2022. It's in Brighton, so please do join us in sunny Brighton. And the abstract submissions are also open. So, and the website is live, so please do go register and spread it in all your professional circles as well. And I think with that, we would be able to, that's the QR code for the conference website. Again, we would just like to acknowledge that this is actually a lot of work going on with, thanks to all of you reporters who would be actually submitting the reports, allowing all of this analysis to actually happen. We also thank our MHRA colleagues and the wider short steering group and working expert group members and the UK Forum for funding. And we have the whole panel, the pulmonology, pulmonary working expert group panel here to actually answer all the questions. I would request all of them to actually then start, coming on to actually start the questions.
Thank you so much, Ruthie, and thank you to Dr. New and to Dr. Gray for a really fascinating presentations. So if you want to put your questions into the chat box at the bottom, into the Q&A box, feel free. I know I can see some questions coming through, so I'll start at the beginning, but do feel free to keep adding. We will get through as many as we possibly can. So right back at the very beginning, a question from Rika? And this is directed to the team. So Charlie, it says INX, I'm assuming it means investigations involve donor and patient testing, and many times the results are inconclusive. So how can it be ascertained that it is Charlie and not due to an existing condition?
Okay, I suppose I should take that one. Thank you, Reka. Well, yes, I was smiled at Sharon's description of pulmonary complications as a Möbius strip, because a Möbius strip is non-orientable, and I'm very confused about Charlie definitions following the consensus classification. I think that the difficulty with it is that since this classification, people use Charlie to use different things in different ways, and so in the consensus classification, Charlie is viewed as a transfusion complication which is mediated by endothelial permeability, which might not actually have anything to do with antibodies in the transfusion at all. However, the way that most people use Charlie in everyday practice is meaning that in some sense something in the blood caused the reaction. I think the key is to think about why you're doing the investigations. So in from a blood service point of view, we're kind of interested in the question like, were there antibodies in the donor that caused the reaction, so that we can withdraw that donor. And so the likelihood that the antibody caused the reaction can be informally considered by considering how much of the features of the reaction were explained by the underlying condition. How surprised were you that the reaction happened given what you knew about the patient before? And the second consideration is the number of units that were transfused. So the more units transfused, the more chance there is that the antibodies that you found in the investigation were just incidental. And so so it takes into account both those features. If that sounds like a slightly vague answer, it is at the moment, and there is a sort of mathematical formulation that you can apply to it, but it's not easy.
Oh, that's super. Thank you.
Great. Thanks, Tom, for that explanation. Got a really good question here from an anonymous attendee. Will we have a TACO checklist for children soon? Good question.
Is that for me?
Anybody? Yeah, Sharon, yeah? Or Helen?
Sharon?
Oh, no,
I
sorry,
think
Helen, now did
question
yeah.
answered by Helen, yes.
I mean, I hope I slightly preempted that one. I mean, I think that the current checklist, as I say, I think the general principles in there are completely relevant to children and actually also to neonates in many ways. I mean, clearly some of the specifics, particularly for neonates, would need more adaptation, and there are specific areas, as I mentioned, things like neonatal exchange, which could have a particular mention. And pragmatically, either this could be done locally or we could do this within SHOT. But I think the current checklist principles in there are key, even if, for example, specific diagnoses or cardiac diagnoses would be different.
Thank you, Helen. The next question is from an anonymous. It says, is there any evidence that the use of the TACO checklist is reducing the incidence of TACO? That's a general question. Whoever wants to be brave to answer that one.
Shall I answer that one?
I can add to that later. Go ahead.
The short answer is no. But I think a good analogy is the VTE risk assessment that we do on our patients for venous thromboembolism, which NICE asked us to do many years ago. And actually, that is not validated. And I would stand a bit to be corrected, but I don't know that there is any evidence that it is reduced morbidity. I think that work needs to be done, and I would say, the TACO checklist is analogous. Now, what I would like to say is that SHOT introduced this it was published in 2016, it was a 2015 report, and so we've had a number of intervening years, and what I would like to say is that it would reduce the incidence of TACO, but what we do know is that what is reported to haemovigilance organisations does not equal the incidence of TACO. There is a disconnect, so that would not be a suitable tool to measure that. So I don't know how we would measure that, but like the VTE checklist, the fact that we don't have that evidence does not mean to say that we shouldn't do it.
Thanks, Sharon. I think 2 points that I would like to add is I think we'll never know if a checklist is useful or not until we actually start using it. So I think it is really important. As Atul Gawande, who wrote the checklist manifesto, say that only checklist that does not work is the one that is not used. So I think it's really, we need to use that. And the second is, I think, right, as Sharon pointed out, it may not be with respect to the incidence, but what we would be able to know is this risk assessment pre-transfusion helping us introduce those mitigating measures, and the outcome in these patients may be actually then better rather than actually resulting in a major morbidity or the death of the patient. So I think that is actually something, again, when we start getting more data where the checklist has been used effectively, would be actually useful to know. Thank you.
Yeah, there's a point, sorry, Simon, and there was a point made by Dr. Chowdhury. It says, especially important to remember to do TACO checklists for every patient before prescribing, especially if prescribing electronically, as the visual cues present when prescribing on paper you'd normally have by the bedside aren't there. So I thought that was a really interesting point.
That's good.
Sorry,
thanks,
Simon.
Nikki. Yeah, some really good questions coming in. I've got one from Katrina Ivo. Hi, Katrina. Would patients who suffer from long COVID or who have indeed had COVID need to be included as a risk factor for TACO going forward? It's a really good question again.
I wonder if Puneet or Andrew want to take that question first.
So, Andrew, do you want to, or shall I just?
No, I'm quite happy to start off, and perhaps we can. I'd be interested in your thoughts as well, Puneet. I think this is really quite a difficult one, because we know even patients who have had COVID can have long-term complications, some of which can be characterized into long COVID. And specifically, they can have some persisting respiratory complications, ongoing interstitial lung disease problems, for example, which I think in that context should be added in terms of the background and a potential risk factor for TACO in these sorts of circumstances. And also, you also have to think about the potential cardiac complications. Some patients with COVID have had associated myocarditis and impaired cardiac function, which may even be a slightly greater risk for TACO
and indeed subsequent trolley in these circumstances as well. So I think it has to be taken into context, but there are certain features that suggest COVID can be an increased risk factor. I'd be interested in your thoughts, Puneet.
Yes, I agree with everything you've said, Andrew. Unfortunately, at present, there isn't sufficient evidence from studies to support using COVID or previous COVID as an independent risk factor for TACO. Last year, during the actual pandemic, we did receive, as you know, quite a few queries, quite a few reports of patients with ARDS or pulmonary edema, especially in the context of convalescent plasma. And it was quite hard to tease out in those patients whether respiratory failure was a complication of transfusion or whether it was related to COVID-related myocarditis leading to cardiogenic pulmonary edema or COVID-related ARDS. So COVID is quite an interesting area, but at the moment, I don't think we've got sufficient information or evidence to actually formally add on COVID to any sort of TACO risk assessment or a checklist. Maybe something to gather information prospectively on.
I think that would be really, really helpful. But I suppose if we can actually identify and try and nail down some of the underlying physiological and pathogenetic sort of mechanisms which have resulted from having long COVID, they can then be some of the features that may then ought to be considered into a panel as a potential risk factor then. So I think it's about trying to dissect that out, but we need more evidence, don't we?
Yes.
Thank you. Question to the whole panel. Should there be a blanket policy of giving prophylactic diuretics for routine transfusions?
Sharon, do you want to start?
Just unmute myself, sorry about that. Yeah, so there was a Cochrane review back in 2015, and there were only 4 randomized controlled trials that looked at giving prophylactic diuretics to patients before transfusion with the objective of reducing transfusion-related morbidities. In a nutshell, what that found was it didn't find either way whether or not that's a good thing or a bad thing to do, but unfortunately TACO wasn't one of the endpoints that was studied in any of those 4 studies. I think it did find slightly in the favour of furosemide in terms of an improvement of pulmonary wedge pressure, but again that's an indirect kind of measure. So I think the short answer is that we do need better randomized control trials, because having a blanket approach to giving any drug is probably not a good idea. There are certainly contraindications. There are patients who are vulnerable to the side effects of diuretics, especially in the elderly, sort of hypotensive type of reactions. You do not want somebody passing to a blood transfusion, getting up to go to the toilet and falling over. We will be replacing one problem with another. So I think more work needs to be done to answer that question.
Thanks, Sharon. I think the only other point that I would like to actually say is that also the other side of it is just somebody due to other reasons are on prophylactic diuretics or regular diuretics, that should not result in a complacency that they are on diuretics and they wouldn't be actually needing. So I think it's all about making that individualized transfusion decisions, assessing the risk versus the benefit on a case-by-case basis. So I think you know the patient best, and also it is actually important to look at the fluid balance as well as a recent body weight. And I think in the national comparative audit, it was also mentioned it is actually a body weight within the last 7 days. Now in pediatrics and neonates, we are more used to more regular, almost a daily weight check as well in the sick neonates, but in adults that does not happen. So it is important for us to actually be getting that. And if they are the risk of the lower weights, then again go back to a weight-based transfusion decisions.
I think that's important, isn't it, Shruti? Because I think it's quite important to highlight that the focus really should perhaps be around the individual sort of risk assessment, and then thinking about mitigating circumstances, which is where diuretics come in. Because as both Sharon and yourself have highlighted, they do have their side effects, and you can replace one problem with another. So it's about reviewing the context.
Thanks, Andrew.
Yeah, thanks, Andrew. A very quick question, which I can answer really, and it's from Robert Johnson asking, who's responsible for reporting to SHOT? He's not sure he's been aware of this before. Well, that would be the transfusion practitioner or hemovigilance practitioner within your hospital, Robert. I'll send you some details on the answer in the question and answer section. I'll type that to you now. Thanks, Nikki.
Yeah, I've got a question from Alicia. It says, working with hematological malignancies, our patients require lots of transfusions and have higher HB and patient thresholds. They often also have underlying cardiac conditions or are on diuretics. We are strict with our weights and fluid balances, but what else can we do to prevent TACO in our complex patients?
I think it comes back to making the right transfusion decisions and questioning whether you really need that transfusion, as well as the urgency, and also whether there are alternatives available. And if a transfusion, we are not saying that a transfusion should not be actually given, it's also ensuring that the transfusions happen in the daytime with monitoring that is available. So as we are actually saying, all of this is a risk assessment. It does not necessarily say that doing this would reduce the risk of TACO completely by 100%. They can actually still get despite all the management, and therefore it is really necessary. Don't hold back the transfusion if it is needed, but make those decisions based on the indication, alternatives, risks, and benefits, and monitor the patient as well. So what you really don't want is a vulnerable patient coming as a day case. Again, that element of patient education is also really important when we have several cases where patients come in as ambulatory, multi-transfused patient. The patient has not been really educated, goes home, has respiratory distress. So although the type of patient that you're actually saying would be more likely to get as an inpatient, again, understanding the transfusion threshold, the justifying that need, and assessing the risk is what I would say. I don't know if Tom, Sharon, do you have anything else, and even Helen?
Yeah, I did have something that I think there is further work to do about is there a way of monitoring whether preventative interventions such as giving diuretics were effective enough, or like, in other words, okay, you gave the diuretic, but did you actually get enough diuresis with it? I mean, I think we see, I can't remember, was it something like a quarter of the cases which had checklists did actually have all the mitigating actions performed, but they still got TACO. So you ask, were there further, were the mitigating actions done but not sufficient?
Thanks, Tom. Still got time for a couple more questions. A question here from Jill Clarkson. Hi, Jill. One of the problems is that TACO is underreported. Is this still due to the concern about blame, although we know the aim is lessons to be learned, and the use of the word overload, which may have negative connotations? Is there less reticence in reporting into the other pulmonary complications? Thanks, Joe.
So let me take the thing about reporting, underreporting as well, and then I think Sharon would be able to say, add more as well. So I think in general, overall, when we look at the short report, we have an excellent reporting culture within the country. So I think, and we do promote that it's a just in reporting, and there is a, lower threshold to actually share what we are actually learning. And I think we really thank the reporters for that. Having said that, there are actually categories, including TACO, where we see there is underreporting, as we see from the graph that the National Comparative Audit almost acted as a prompt for people to start reporting as well. The important is the reporting happens through the nominated people within a trust. And if they are not really aware, so TACO may be happening in any medical or surgical ward, and if people are not really aware, that reporting may not happen. So I think, it is, rather than the fear of any repercussion, it would be actually more the underreporting because of lack of awareness that this has actually happened in the other. Sometimes we also see in a retrospective case review that they have actually then looked at that incident, and then they have thought, okay, there is a possibility that TACO or similar pulmonary complication could have actually resulted. Then we accept there is no time limit, and even in an audit or any other reason they have found out, we would accept those reports. So I think that is about the reporting. I forget what was the second part, but maybe Sharon wants to add, and then we can take the other part.
Yeah, I mean, I was going to say something quite similar, really. I think one of the things that the National Comparative Audit showed us is that, yes, there is underreporting. We always knew that, really. It just kind of gave us evidence to support what we thought all along, really. But I think one of the other things that it did show is that there was under-recognition as well. So I think in an organisation, in a hospital, it's important that, one, there is a culture of reporting incidents and errors in blood transfusion, on as a top line kind of thing, but also having some promotion on pulmonary complications of transfusion. Of course, TACO is a leading cause of transfusion-related mortality and major morbidity. So having specific awareness of the pulmonary complications is so important, because we know from that National Comparative Audit actually it's highly under-recognised too.
Thank you, everybody. Unfortunately, we only have 2 more minutes left, so I'm going to hand you over to Emma, who's going to. But thank you for all the answers and all the questions out there as well. So I really appreciate it.
Yeah, and I just want to add, sorry, Emma, just wanted to add, if anybody has any burning question, please do email us. We may not have taken all your questions. Please do email the shortened box. Over to you, Emma.
Yeah, absolutely. Just to echo what Shruti and Nikki have said, thanks for all those great questions. Loads as we expected, because it's such an interesting and evolving topic. If you do have questions, the SHOT email address is shot@nhsbt.nhs.uk. I'm sure someone will put it in the chat box there as well. And we will do our best to answer any questions. So the last few minutes, we're just going to do a live poll. So we'd really appreciate you just taking a minute to complete this. It helps us guide our future resources and webinars as well. So the poll has appeared there on your screen to submit your answers. And then once you've submitted your answers, at the right at the bottom, you'll see the submit button, if you could just press that. And one of the things we ask is if you're watching it in combination with other people or whether you're single, because again, that just helps us guide our participant numbers in the future. So while you're just finishing off answering those questions, I'd like to remind you that this session has been recorded and it will be uploaded to our website as soon as possible. And we really do appreciate your feedback. So any comments and suggestions about haemovigilance and the work that SHOT does, please do get in touch by phone or email. Please do visit our website as well, and that's www.shotuk.org, and you can see there our reports and our activities and various resources, and those are freely available for you to use in your educational activities in your own organisations. We are regularly updating our SHOT videos and bites.
This meeting is being recorded.
Sorry about that. So any suggestions are of course welcome on a regular basis, and we'll take a look at those. Have a look at the website and feel free to use those resources. And just as we mentioned earlier, SHOT do have an app which you can download by putting in the search button, and if you search for SHOT UK in any search buttons, you'll be able to access that. And just with my patient blood management head on, if I could just mention a resource called the Blood Assist app as well, which in my intensive care days I wish I'd had that at my fingertips, and that has TACO risk assessments on it as well, and I think Jess is going to put the link in the chat there. That's a really useful resource for TACO prevention. So finally, a huge thank you to all our speakers and to all of you for joining us, and we hope to see you again very soon. Thank you.
Thank you. Bye-bye.
Thank you.